There we go. All lines are muted. Um, Please send questions in the Q&A option at the bottom of your screen. You can also feel free to drop things in the chat. We will be having a Q&A session at the end, and I'll be moderating those as well. The presentation will be available to view after the webinar. And for the convenience of those of you who might be hearing impaired or just need closed captioning, captioning has been turned on. And we will also have some polls later in the slides. And so we hope that you will participate when they pop up on your screen. Just a little bit about Accessia Health. Accessia Health is a national nonprofit dedicated to addressing the needs of people with rare and chronic conditions. We have a very unique approach to traditional patient assistance that is holistic, inclusive, and outcomes focused. Our disease-based programs cover a variety of healthcare expenses, including copays, premiums, and travel. You can learn more about our organization at our website, accessiahealth.org. Accessia Health webinars, events, and conferences are intended to provide information to the public. The views, opinions, or the views and opinions expressed by any of our speakers or other third parties are not necessarily those of Accessia Health. And without further ado, I am very pleased to introduce you all to our speaker for this afternoon, Dane Christiansen. Dane has worked in government relations for more than 20 years and specializes in advanced medical research, treatment development, and patient access related policy goals within the rare and chronic disease communities. Additionally, he has a background in grassroots organizing and healthcare advocacy, as well as a detailed understanding of the federal budget and appropriating process. Dane, I will hand it off to you.
Thank you very much. And I am joined by my colleague, Kira Flaherty. I'm from Chicago originally. I talk very quickly. I'm lucky to have Kira here. Kira is much more direct and to the point most of the time, and also an expert on the appropriations process and healthcare with a healthcare background in her own right. So a couple of things I want to mention about how we approach advocacy. We are focused on things like connecting people with their legislators to tell their personal story. The fact that your voice counts is going to be a regular theme, and the fact that policymakers rely on these types of stories to know how to shape policy correctly. This is something that will come up a few times. We're all familiar with the situation with healthcare costs and inaccessibility in some ways. This is something that, of course, the government will deal with, but they will deal with this through interactions with patients. There are a couple of policies, particularly that can affect people's access to care. Copays is one of them. Prior authorization is another. Step therapy is another one. These types of cost-sharing requirements you may be familiar with, and that's why we say telling your story is important. Policymakers and your members of Congress will shape what's happening legislatively, but they will make these decisions based off of input from their constituents, you. So they can make these decisions with your input or without it. Much better that they make them much better that they make those decisions with your input. They're not going to be researching this information on their own. It's brought to them by people who take the time to speak out. And of course, our goal is to do things like preserve the physician-patient experience so that you and your doctor are making healthcare decisions, but also to deal with things like out-of-pocket costs. And out-of-pocket costs doesn't always mean what some middleman might have to do. It means, what are you paying personally? Is your requirement or your burden too much? And that's what matters most at the end of the day, not the list price of some drug or the cost of some surgery. What are you being asked to do out of pocket? And is that restrictive in any way? And that's where those stories come into play. I will make one disclaimer of my own before we move on to the first question. Kira and I will answer questions at the end. Neither of us are certified insurance navigators. We are experts on policy. We can answer questions about what's going on in the Medicare program. We can't answer a question about whether you have the right to Medicare policy or not, or something that would be going on specifically. Though Accessia Health, I'm sure, has the resources to help answer those questions. not necessarily the right, Kira and I would not be the right person to answer them. So technology and I have an interesting relationship. I should be able to advance the slides here. And the first thing we're going to go to next is going to be a quick question. Gabrielle is going to be nice enough to help us answer this. I'm going to leave this up for a moment. How many of you or someone you know have delayed or skipped care due to out-of-pocket costs? And this helps inform what Kira and I do every day. Are these policies restrictive? So we're going to pause for just a few seconds to give everybody time to answer them, and then we will move on with the presentation. But please, even though your information is not personalized, your responses are important. It helps us to identify some of these issues that would cause a frequently or occasionally. All right, I hope everybody had a chance to reply. And what we can see is occasionally and frequently, unfortunately, 7 out of 10 responses, only a few in the rarely and almost no responses of never. So this is going to be a significant topic that comes up as well. What is causing these frequently and occasionally? And the fact that if this is you saying yes, even if you were in the rare category, telling your members of Congress why this is happening helps them solve those problems so it doesn't happen again. And as I mentioned that, I will just say really quickly that the government, of course, has a key role to play in everybody's healthcare. So you might think of healthcare as something that goes on between you and an insurer, or you and your health center, or you and a hospital or your doctor. But of course, the government, the administration, the Congress, the courts to a lesser extent, but also an important one, are all playing a role in your healthcare. And basically what happens is there's a continuum. There's a continuum of healthcare. It starts with medical research, just investigating various diseases. Then it moves on to treatment development. Has the benefit of that research led to new therapies or treatment options in the pipeline? And then once therapies, surgical techniques, medications are coming to market, are they accessible? What is the deal with out-of-pocket costs? What is the deal with coverage? Can you actually utilize them? Your voice is important in every step of that process. Do we need more treatments? Can we utilize the ones we already have effectively? And this is a message that's important for your legislators. Government decisions will always shape healthcare, and not just access, but also innovation, that research side as well. And this is why we say, even like if you're a rare disease patient, very important that you speak up, because of course your voice being heard matters a lot more, particularly on that innovation front, to make sure that there's even a capability of developing that research and pushing those types of treatments forward. Elected officials influence every step in this process. We'll talk about that a little bit moving forward. And then, of course, policy changes that happen in Washington end up affecting everybody. There might be things going on at the state level. Your state might be discussing things like prior auth reform or copays, but the national laws that are made is the standard for everybody. The states would have to at least meet that coverage standard, if not go beyond it. They could not be less than that. So the changes that happen at the federal level tend to happen for everyone. And your voices help guide modernization and fairness in healthcare. And the reason for this, of course, is when you have a system like ours with representation, anybody can reach out and make their voice heard. A manufacturer, an insurer, everyone can say what they think should be done and why. But what your member of Congress is most looking for is what you think. Is the system working or not working for you? They know that you have a pure self-interest, whereas some of these other stakeholders might have an agenda, and they want to know if what's being told them is the truth. And the truth for them is, are you getting the care you need? Is this process working for you? And are you paying your fair share, or are you being asked to pay too much? Or to that last poll question, are you making tough decisions as a result of some of these policies? Explaining this to your members of Congress will help them solve these issues. They care much more about what you, their constituents, are saying and their voters than what some company that has an agenda might be saying. And when it comes down to how you effectively talk to these lawmakers, it's not all about, bill numbers. And, people think of it like you think of going to court or being part of a jury or something like that. You're not making a case. This isn't the debate team. You are simply telling your personal story. In most cases, there is not an opposing person with a different story. It's simply a lack of awareness. Congress is very busy. They have a lot of things to work on. How do issues rise to the level of significance to ensure that they take action? And how do enough members of Congress take action to form a critical mass of support? That comes down to personal stories. People saying, this is what's happening to me, and this is what I need help with. And of course, there might be coverage, access, out-of-pocket cost decisions that are rare disease specific or condition specific, but usually these are one-size-fits-all policies. So if you're struggling with something, or if you got a notice about either federal coverage or private coverage being problematic, a bunch of other people probably got the same thing. But those personal stories matter. Not trying to put it into partisan terms or political terms. Ideology is really irrelevant here. The important step in the process is simply telling your member of Congress who's there to represent you what happened and how it's disruptive and what help you need. Being taking that pure self-interest you have and explaining things in honest and direct terms gives them the information they need to make policy changes, regardless of what anyone's political persuasion or politics might be. You should have every expectation that if you share this information, it will have an impact. But what you also want to do, once again, particularly if you're a rare, serious, life-threatening condition, is explain the nuances of your situation so that you're not being lumped in with a one-size-fits-all solution. A good example of this is there's always a lot of talk on Capitol Hill about healthcare savings accounts and using healthcare savings accounts. Great idea, but not for everybody. If you have a condition that has a lot of out-of-pocket costs and they're occurred early in the year, a healthcare savings account is largely useless. Making sure a member of Congress knows why that doesn't work for you wouldn't take the benefit of an HSA away from anyone else, but it might mean that for certain people, they have additional options or different coverage to utilize. That's the type of things they're looking for. You can even develop some flexibility within the system that's more localized and personalized. And your voice is one of the most powerful forces when it comes to producing better, more cost-effective, and more inclusive care. We have another poll question here. Have you ever shared your personal story? I believe, yep. Have you ever shared your personal healthcare story with a policymaker, advocacy group, or on social media? So very simply, if you're aware of the power of your anecdote, whether it's an elevator pitch told very quickly, or whether it's lengthier, a whole kind of op-ed or article that's been written, have you ever taken the step to make your voice heard? Yes, no, or planning to. And we will move along in just a moment. All right, not surprising. Only about a third of folks have said yes. Our goal is to make sure more people understand why that matters. So while around 30-40% is great, not surprising. But of course, the more the merrier, so to speak. So the more of these voices that are heard, the more significant the impact can be. We often work together to create progress. So now I want to do a little bit of a Civics 101 refresher, just to remind people why your voice is so important, why we have a system that's set up where the constituent information matters, and just how to be effective in that environment. So of course, if this might be a little too remedial for some folks, but I promise you it's for a greater purpose. I'm going to invite Kira to help me out when we get into some of these legislative issues as well. But this stuff I hope I can handle. We have three separate co-equal branches of government. We have the administration and the White House and the federal agencies. We have the Congress, the House and Senate, your representatives and senators, and we have the courts. And the way that the system is set up is that the administration and the agencies are not that interested in patient stories and what people are going through. It's not their function. Similarly, that's not the court's function either. The court's function is to read and interpret the law, but it's your senators and representatives' job to make the laws, to decide how money is spent, whether it's on research or something else, and to bring these policy issues to the fore. In fact, primary responsibility and the most authority in this regard goes to your senators and representatives. Now, sometimes if you have one party in control of the White House and one party in control of the House and Senate, it may seem like they're always working together, but that's only true in a very limited way. The function of the House and Senate are different. The function of the House and Senate are to take information from constituents. It's a member-driven process. and the members are driven by you, the people they represent. So that's what your senators and representatives are looking to. They're looking to you for guidance, especially on some of these issues. So how this works is that everybody, if you're in the United States, has two senators for your state. So New Mexico has two senators. And then there's 435 House representatives. Everybody has one House representative. Congress has the power of the purse. So only Congress can decide how money is spent, how much money goes to medical research, how much goes to the FDA, how much goes to the FBI or the Coast Guard or anything else. Your only Congress can decide that by passing spending bills every year. Congress also has oversight of federal agencies. What type of research is getting done? How are agencies working for people that have coverage and access issues? And of course, they're the ones with the primary authority to change the law. If something's not working, I think everyone remembers Schoolhouse Rock. A bill can pass the House, pass the Senate, be signed by the president. That would change how things work. Medicare coverage policy is one of the most common examples in this regard, because how things are covered has to be written in law. And of course, innovation and science can move forward faster than the law can. So oftentimes there are new things coming to market or new advancements, but coverage hasn't caught up yet. What makes sure Congress prioritizes those types of things like modernizing coverage is by hearing from people who are affected that the coverage isn't working for them, and then they can work on changing it. So I also want to mention that we had an election a couple years ago in November that brought us a new Congress. So we had the 118th Congress, or the 119th Congress, which started in 2025. And then, of course, we had a presidential election at the same time. And we had a new administration, which is kind of an old administration. So Donald Trump was elected 45th and 47th president. So first president since Grover Cleveland to serve two non-consecutive terms, but it told us a little bit from the first term for what we should expect with the current term. And one of those things that we'll talk about is the importance of what Teddy Roosevelt would call the bully pulpit and public relations. And there's a difference between public relations, going in front of a podium and saying a bunch of stuff in a country that has free speech, and actually changing policy. Of course, the system that the founding fathers set up and that we still follow, no one person, even a president, can change the law by simply saying that they want it changed. Anytime the president says, I think we should do this differently, it almost always goes through Congress, which means senators and representatives and people who care about what you think about anything that might be happening. Congress prefers the status quo, whereas the administration prefers a lot of new ideas. And there's been a lot of work in those three separate co-equal checks and balances. Even when it's this, you might have a Congress and the White House that are the same party, they don't always agree on everything. And Congress says, we're going to stay in our lane, you guys stay in your lanes, and the courts stay in their lane. So even though it might appear that there's a lot of overlap, the system is really such where the members are saying, geez, what do my constituents think about this, whether it's federal funding or policymaking? Your voice will count no matter the composition of Congress and no matter who's in the White House. And nothing that gets discussed is political. So it's really about educating folks that are making these decisions about what you need and how they can help you. And we'll show a few examples of how that's been impactful recently. But just to make level set on exactly how federal healthcare agencies and Congress are involved in your healthcare, let's talk about what they do. So Congress, of course, has a few functions. The Appropriations Committee in Congress passes spending bills every year for everything in the government. And if they don't, we have a brief or sometimes not so brief shutdown, but they must pass federal spending on an annual basis. There's also a number of healthcare committees that handle medical research and public health issues. And there are insurance committees that handle Medicare, Medicaid, out-of-pocket costs. And then, of course, if you have TRICARE, there's a military committee that cares about that. If you have veterans coverage, there's a VA committee that cares about that. So there's lots of oversight on the congressional level. But what the key federal agencies that we talk about on that continuum, it starts with the National Institutes of Health. NIH is the world's foremost biomedical research enterprise. NIH is funded at about $48 billion with a B dollars annually. That might sound like a lot of money, but it has to cover an awful lot of conditions, thousands of diseases, from COPD to hereditary angioedema and on and on. So when that money starts getting divvied up between those conditions, you have different portfolios. But of course, the money does not stay in a government lab. It goes out to academic health centers all across the country. So if you see on 60 Minutes that the University of Massachusetts has developed a new device that might help someone who's paralyzed walk again, or that Baylor has a potential new treatment for Alzheimer's disease, that work was largely funded by the NIH. The scientists competed for those grants. They had the best ideas and they got the awards to do the work. So the money goes out all across the country. But the key thing is, of course, the more money there is for research, the more research gets done and science moves forward more quickly. The FDA is a regulatory agency. The FDA does not develop new treatments. Private companies do. Drug companies make them. The FDA simply decides if a product is safe and effective. And it's a sliding scale for how safe and effective. But once again, the patient voice matters because you might have one treatment approved and it might be okay, but it's not great. But you wouldn't want the FDA to say, well, geez, we already approved a treatment here. So do we really need another one? You might be able to answer that question with a yes better than some scientists might be able to, who has to cover a whole bunch of medications to get reviewed all the time. The next is the Centers for Disease Control and Prevention. They are a primary public health agency. They do public awareness, they do professional education, and they do surveillance information. So how common is a condition like pulmonary hypertension or hereditary angioedema? Or have we seen 5-year survival rates in different cancers? The CDC puts all that information together. And then, of course, the Centers for Medicare and Medicaid Services, as the name suggests, oversee Medicare and Medicaid, but also set the rules that private insurance follows as well. And once again, Congress is helping and playing a role in all of this. So, what are some key policy items from last year that the administration was taking the lead on? So 2025, the start of the 119th Congress. A couple of things I want to make note of, as I mentioned, the administration doesn't have a lot of ways to make laws or policy themselves. They can say lots of stuff, but Congress ultimately has to adopt it through some type of process, and a process that we know what's happening and that they care about what their constituents think. The administration asked Congress to cut funding for Health and Human Services by 22% and the NIH for medical research by 40% and reorganize public health agencies. And you might remember also end the Department of Education. This was a key policy proposal. There's also been a big focus on out-of-pocket costs and medications and an effort called TrumpRx.gov, which has not been about creating change necessarily on the policy level, but working with companies and other stakeholders to do things voluntarily to lower certain costs. And there was something called a reduction in force and funding review that the courts had to deal with. The administration said, we're going to freeze some of this funding and we're going to change how some of these agencies work. And the courts, in that separate co-equal branch of government map, said, you can't do this. If you want to do any of this, including ending the Department of Education, then Congress would have to pass a law to do that. It can't be done just because the administration requests it. So, of course, now that you're saying we're going to have to pass a law to do that, it's in the purview of senators and representatives. And what they want to work on is not what the administration has flagged as important, but what their constituents have flagged as important. So they're more interested in the people who are meeting with them and telling their stories and saying, okay, this is an area that really requires my attention. That's how they make those decisions. So what are some key policy items that the Congress decided to work on from last year? And so the 119th Congress, of course, had something that they were really interested in called the One Big Beautiful Bill Act, using a mechanism called budget reconciliation. That means that normally on Capitol Hill, every bill has to be bipartisan. If you don't have support from both parties, it can't move forward. Every once in a while, you can write a bill that can pass with one party support, provided you have a bunch of rules. And that was the One Big Beautiful Bill Act, which was changes to Medicaid, CHIP, and SNAP. It was called a budget bill. There's a couple of things to know about that in a moment. There was also a brief government shutdown that occurred when funding lapsed, but you might remember the discussion that happened out of that shutdown was about healthcare affordability and expiring premium tax credits to help lower healthcare costs. Congress had said, we've moved on from some of these healthcare issues. We're just not working on that right now. But voters and constituents said, we have other ideas. And they had other ideas because they were not happy with what they were being asked to pay for coverage. So because this was important to people, constituents across the country, it became very important to Congress once again. So in some respects, you are the one setting the agenda for your legislators. And Congress completed the last round of spending, what they call the fiscal year 26 appropriations bills, and provided some notable things for research and public health. We'll dive into a little bit more deeply here. So first and foremost, a couple of things to know about the One Big Beautiful Bill Act. It's very big. It affects every single federal program. We're going to talk a little bit about healthcare. And I'll, of course, invite Kira to jump in on any of this if there's something that she thinks is significant. But the key healthcare items was, of course, there was a big push to reduce federal spending. So reducing federal spending means that benefits would become less generous. So there were new calls for work requirements and regular eligibility checks in Medicaid. So if you were checking work requirements or eligibility once a year, maybe you check them 3 times a year now. This is a hoop that patients have to jump through that makes things more complicated, because the burden, of course, is if you skip one of those eligibility checks, you lose eligibility. It's on the person to make sure they keep up. There was a reduction in federal Medicaid spending. The tax credits for the Affordable Care Act that we were talking about were sunset, which is what voters responded to by saying, we need to fix this problem because now we're paying way too much. And that's why Congress is focused on this again. They started a $50 billion fund for rural health, which sounds like an awful lot of money, but I'm going to remind folks this other bullet point on the other side, which is these are 10-year bills. So that's $50 billion over a 10-year period of time. And they use the mechanism to improve physician payments, particularly how much doctors get paid for seeing Medicare patients. Of course, if doctors get paid less to see Medicare patients, then maybe fewer doctors do it. So fixing those payments means there'll be more access through the program. A couple of notable items, in addition to the changes in Medicaid, is that there were changes to the Supplemental Nutrition Assistance Program. I mentioned that because I think there's growing awareness that nutrition and health and disease are all very closely linked. Even though there has not been a lot of work done previously, everyone, the scientific community is very much getting everybody brought around that this all needs to be looked at together. Another thing that happened was there were loan caps put in for everybody. This is one of those one-size-fits-all solutions. Of course, there should probably be a loan cap if you're trying to get a European history degree, and then a job wouldn't be able to cover the cost of your student loans. But if you're a doctor, medical school is very expensive. So having a loan cap for doctors that's the same as other professions would make it harder for people to become doctors if they needed to use the loans. So if you want to have a geographically diverse and economically diverse workforce, you would need to make sure that anybody can become a doctor. So I mentioned that because there's likely impacts for health access, particularly in rural and underserved communities moving forward. But once again, this is a 10-year bill. Nothing happens immediately. This Congress is only around for this year and last year, and then a bunch of new people who are going to be here depending on the elections. They will revisit all of these issues. So if many of these things have not even been phased in yet, they're phased for future implementation. But of course, if people say, hey, this is a problem for me, Congress will revisit these issues moving forward. But it's going to be based off of, once again, those stories and people explaining what the biggest challenges have been. On the funding front, I'm just going to bring this back full circle for the proposal I made earlier. I mentioned that the White House had asked Congress to cut funding for research by 40%. Well, Congress didn't do that because when they write the spending bills, they listen to their constituents. Medical research and patient care continue to be very popular, the same way that the community said we have to deal with these premium tax credits and healthcare coverage costs. The final bill that got passed on January 30th of this year didn't cut the NIH by 40%, but increased medical research funding by $400 million. It also provided $850 million in funding for the DoD congressionally directed medical research program. So an increase instead of a cut. The VA research program was also increased by a few $1,000,000. It maintained funding for all traditional activities, more or less. So the agencies were kept intact. They just had more money. And they didn't include any new MAHA spending yet, but this continues to be a discussion. But of course, if there's a need to fund more pediatric disease, more chronic disease, Congress has a way to do that. And if you say, I have a rare disease or a chronic disease, and I think there needs to be more research funding, you should have every expectation that your lawmakers are going to respond. Congress also included a bunch of policy riders saying that the White House and the administration cannot interfere in research, because this is something that they heard about from their constituents and from the scientists who they represent that are actually doing the research themselves. They had policy riders for non-interference, maintaining something called indirect cost policy, restricting multi-year grants so more scientists can get funding. But they also provided a 2-year extension of telehealth, and they passed a couple of bills that we support. The Kids Access to Care Act, which lets kids in the CHIP program and Medicaid see doctors across state lines without going through a bunch of red tape, and a bill called the Give Kids a Chance Act that's meant to fix rare disease treatment development and also reauthorizes something called the Pediatric Priority Review Voucher Program for treatment development at FDA. This was a train leaving the station, and Congress attached a bunch of healthcare items to it. So good news at the end of the day, but good news because people spoke up, spoke out, and Congress responded by including the things that they were asking for. And then for 2026 outlook and key items, so that's where we're at right now, but where are we going moving forward? Congress is now working on fiscal year 27 spending. It's a constant cycle. They just finished fiscal year 26. They gave NIH 400 million more. They gave the DoD 850 million more for research. Now they are writing the FY 27 appropriations bills. And once again, when they're writing these bills and deciding is money going to the CDC or NIH or somewhere else, those stories matter. Patient stories matter. Saying this has been my experience, we need more research or we need more treatment development matters to members of Congress who are making these decisions. Congress is also working on a broader healthcare package. Now, affordability is the focus again. So if you have an affordability story or experience with out-of-pocket costs or coverage issues, now is the time to tell your members of Congress about it to make sure it's reflected in whatever bill is being worked on. You don't have to memorize bill numbers. You don't have to know about how legislation is drafted. You just have to know what your story is. By telling it to your senators and representatives, it's up to them and their staff to figure out how to utilize the legislative process for you. You don't have to give them a provision that's written like a lawyer would write it. You just have to give them your story. They have to write the provision, but they can't do that if they don't know what your experience has been or what the key challenges you're facing are. And it's an election year, so Congress is particularly sensitive to local requests and personal stories. Everybody has an eye towards November, and they are very keyed into what the people they represent think and think they should be working on. There are also a few bills like the Kids Access to Care Act and the Give Kids a Chance Act that's time has really come. Sorry, I didn't touch the screen, but those bills are on key issues that affect patient care. There's a very popular bill called the Safe Step Act that's meant to rein in abusive practices in step therapy that could potentially be harmful or confront folks that have life-threatening or serious conditions. There's a bill to fix the issues with copayment accumulators so that if you get copayment assistance, it is counted to your out-of-pocket maximum. There's been a bunch of work on this front, but Congress needs to change the law to make it very clear that if you get assistance, it goes to your out-of-pocket maximum and nobody can double dip or take that money and not count it. And then, of course, there's a number of efforts to reform prior authorization so that prior authorizations can't be used to keep people with serious, chronic, or rare conditions from getting the care they need by saying, oh, have you done these 5 prior authorization steps first, just in a way to be disruptive and difficult, rather than having a practical healthcare purpose. These bills are all popular. They are bipartisan and their time has come, but Congress will not pass them unless they continue to hear that the expectation is they get enacted into law. Just like with the last bill, Congress isn't passing a bunch of stuff in what's called regular order. They're not passing one-off standalone bills. It takes a lot of time for them to do that and a lot of debate. They are rolling things up into these much bigger packages. So they are working on pharmaceutical benefit manager reform. This is about healthcare costs. Congress years ago, when George Bush was president, tried to vertically integrate healthcare and said, if everybody is under the same umbrella, then shouldn't we create efficiency? Well, they did that, but prices went up. So Congress is now saying, how did that happen that we made things more efficient and coordinated, but costs went up? They feel like there's something wrong and they're going to try to fix it. They're also going to try to fix something called the 340B drug discount program to make sure it's working appropriately for people who need it and need discounted drugs. And they're working on FDA with a bill they do every 5 years called PDUFA, which will change FDA policy and what the FDA is working on. So as they work on these bigger issues, they can pick up the individual things that you care about, but they can also pick up the Safe Step Act, prior auth reform, and co-payment accumulators. There's a real chance to pass this stuff at the end of the year after the election. And Kira, I would just ask if there's anything that you would add to that.
Thanks, Dane. No, I think you've been very thorough in your review, but happy to help answer any questions at the end.
Great. I just advance the slide, so with any luck, it will advance and not jump to or jump backwards. But okay, I think we're in good shape. So now, specifically, if you're saying, well, geez, how can I be helpful on these issues in addition to telling my story? There are some specific asks. So telling your story is why they care. It's what they can do to help. But we're going to ask for some specific things. We're going to ask them to provide the NIH with $51.3 billion. This is an 8% increase. That $400 million increase last time around was barely budget dust, but it was an increase nonetheless. We want about a $4 billion increase. So add one more zero on there. And then there's a newish initiative called the Advanced Research Projects Agency for Health, which does a bunch of work like the military does, where they just identify an issue like cancer survival and try to solve it. That we want to fund at $1.7 billion, so another $200 million. The DoD research program that they restored all the money to by adding that $850 million, they brought it up to $1.5 billion. We're hoping they'll go another $100 billion. Well, they go to $1.6 billion this time around. The need is great. There certainly needs to be more research. And the community is also asking for a $2 billion increase, billion with a B, increase for the CDC overall to get up to 11.6, and a $2 million increase with an M for a program called the Chronic Disease Education and Awareness Program. This program lets anybody approach the CDC for a cooperative agreement in different areas and to do work that the CDC normally does by saying we need more work in this rare disease or in COPD or something else. It's a competitive pot of money, and an additional $2 million would fund about 6 or 7 new projects with different nonprofit organizations in different condition-specific areas. In terms of the patient care legislation, the Safe Step Act is HR 5509 in the House and S 2903 in the Senate. You might say, well, why doesn't Congress just pass this already? Well, HR 5509 means it was the 5,509th bill introduced in the House. So I'm sure Congress would love to pass it, but they have 5,500 other bills they're thinking about too. They can't pass all of them. They do not have the time. They need to work on what is most popular and most pressing. So telling your story, if you've dealt with step therapy or fail first protocols, gives them that reason to say, okay, this one will be next. Similarly, the Help Copays Act is HR 6423 and S 864 in the House and Senate, respectively. If you've dealt with a copay accumulator or not had any assistance counted to your out-of-pocket maximum, which many would say is not allowed, but Congress needs to clearly change the law, tell your members as part of your healthcare story so that they can co-sponsor and pass these changes. And then, of course, if there's something that you have experienced with affordability in general, I have a rare, chronic, or costly condition, and this is what I deal with. This is what my bills are. This is what I am experiencing. Tell your members of Congress. They can make an impact, not just for you in your specific case, but for everybody who's experiencing the same thing. A couple of years ago, Congress made reforms to stop a practice called surprise medical billing. And surprise medical billing meant that if you were told you need care and you went somewhere and it was out of your network, they're going to charge you a whole bunch of money for making a mistake that you didn't even know you were making. Congress heard about this from enough people and said, this is wrong. And now we've done things to rein in surprise medical billing. No more surprises, no more huge bills, no more tricked or going to see someone who's out of the network. They fix these types of problems when they are aware of them. And they fixed that problem because they heard about it from enough people who said, this is absurd. And they agreed and they changed the law. Most importantly, though, it's your voice. It's not about memorizing bill numbers or funding amounts. It's about telling your story, making the commitment to speak out, talk to these offices, tell them what you've been experiencing. You don't want to be a pen pal or a pest, but you do want to be clear about what you've been going through. Be a resource for them. They are very busy, but decisions are made by those who show up. If you don't take the time to tell them or talk to them, how could they possibly know how to solve this issue for you? Very important tool that you have. And of course, we have a few important tools that can help you get involved and share that story. We have a newsletter that you can sign up for. We have different ways to share your story specifically this year, which we're going to get into soon. There's a patient advocacy committee that you may want to join. You can receive what's called action alerts that say, something like, oh, Congress is getting ready to consider the Help Copays Act. Reach out to your members now and tell them to become a co-sponsor. And then one of those ways to tell your story is by including it in congressional testimony, which is a written story, but telling them, in that way makes it part of the official congressional record. And then we also hope that you will consider joining Capitol Hill Advocacy Day later this year or other advocacy events, virtual or otherwise, throughout the year. But the point is, make a commitment to be involved. You can ultimately decide what your level of involvement is. Oh, and we do have a poll question. So I will read this out loud for anybody who might need to hear it. But which of the following ways would you most like to stay involved in healthcare policy and patient advocacy after today's webinar? Sign up for the newsletter for policy updates as the first choice. Share your personal healthcare story as the second. Join or learn more about the Patient Advocacy Committee as the third. Fourth is receive action alerts on key legislation. 5 is provide testimony or participate in congressional outreach. And 6, similarly, is just say, I might want to attend the Capitol Hill Advocacy Day. So we will give it a moment and then we will move on. Excellent. And there's a very strong cross section of different ways that everyone would like to get involved, with robust support for most of these answers and at least majority support for all of them. So thank you for providing your feedback on that, which will bring us to questions. We also have some resources, but I'm very grateful that Gabrielle is going to help us relay some questions that Kira and I can answer, and I'm very glad Kira can help answer them. And we may have some coming through from a few different points. So if you have a question now, let it be known, and we will do our best to respond quickly.
Oh, I have a couple here in the Q&A. The first one is, are there new Medicare rules in 2026 for first-time prior authorizations required for traditional Medicare step therapy requirements?
Good question. This would be every year, as your question alludes to, they update these rules for coverage, and they do it in a product-by-product way. So basically, if there are new rules like that as the plan year starts, you will be informed, and you will probably notice it in the sense that you might be asked to pay something different or deal with a different process with your doctor than you're used to. A lot of times this stuff boils up through personal experience. It's not just being, reading a newspaper article that something's going to happen. You will notice that it happened either with your pocketbook or with your interaction with your physician. When that happens, and if that happens, then it's the time to flag it and say, this is a real problem for me. So it would be too complicated to go through what the rules would be. The Medicare coverage guidelines are thousands of pages long. So, but if you have experienced something like this or believe that you have, that is exactly the type of access or affordability story that your member of Congress might be interested in. But they do update this on an annual basis for every plan year. The key, there's a discussion right now that's boiling. I won't go on a tangent, but one of the discussions right now is AI in healthcare and whether AI could be used to simply strike people on prior auth grounds rather than being evaluated to save money, rather than being evaluated as the right healthcare decision to make. So that is something that lawmakers are dealing with right now. Do we need to put restrictions in place so that a computer can't just go through and say, oh, all these people didn't hit the prior auth requirement, but the decision is the paradigm is saying to save as much money as possible, not because it's the right healthcare decision to make. So that is changes that could be happening later, but one that Capitol Hill is now concerned about. Would AI be used to simply deny people access to medications they may need, or say that they're not in compliance with prior auth? Not because it's the right thing to do for their healthcare, but just because it's an easy way to save money.
Okay. The next one is, are there going to be premium tax credits in the future? When will there be an update on this item?
Good question. And I'll invite Kira to help chime in here. So Congress, they shut down the government ahead of finishing the spending bills. And they said, we want to extend premium tax credits for the year, the ones that were expiring. The House voted on this and passed a 3-year extension out of the House. Democrats and Republicans alike said, we have heard from our constituents, we are passing this. The Senate said that we are going to announce a deal as soon as we finish all the spending bills. They finished 11 of 12 spending bills. One part of the government is not funded right now today, and that is the Department of Homeland Security, something most people don't interact with very much, but does fund, for example, TSA at the airport. So technically speaking, all those TSA folks right now are working without a paycheck. They will be paid when the government passes that bill, but they haven't passed that bill yet. So the Senate has not yet announced their plan to vote on the premium tax credits until they resolve that issue. Since this dragged on a lot longer than anyone was expecting to, it's very likely to be an election year issue in November. But the pressure is what will cause them to do this. The same way the House passed the 3-year extension, the Senate will pass an extension too if people say, I need these tax credits back. But whether their plan is either to do it imminently as soon as they finish this last spending bill and make an agreement on Homeland Security funding, or they're going to circle back to it at the end of the year in the lame duck session in November after the election. But either way, please expect that they're going to be revisiting this tax credit issue. But remember, one of the reasons they're going to be revisiting it is because constituents have said, this situation is unacceptable, I need help. And that's what will ultimately allow them to take action. Don't just say, geez, I hope they get around to this soon. Say, this is what happened to my premium. And that's what will give them the wherewithal to get something done.
All right. The next question, can you explain the concept of a copay accumulator? How can patients fight against these policies?
Yes. So a copay accumulator program or copay maximizer, there's always different terms, is something that was put in place that said, if you get assistance paying your bill, it will not be accounted to your out-of-pocket maximum. So I think folks, now let's say that you have an out-of-pocket maximum of $10,000. And every time you purchase something, let's say your prescription is $100, it goes to hitting that $10,000 maximum. And when you hit that $10,000 maximum, you have no more out-of-pocket cost. The idea of a maximizer program or an accumulator program is saying, okay, if somebody stepped in, a charity, your neighbor, anybody who's not you, and pays for that copayment, then that's not counted. The money only gets counted to the out-of-pocket maximum if you paid it yourself or a direct relation by blood or marriage. So people were quick to point out and saying, well, the insurance company not counting my money, they're still taking my money. So they're double dipping. They're getting the assistance money and they're telling me I still owe them more money. This is something that Congress understands and thinks is wrong, the patient community, led by HIV and Hepatitis Policy United, also sued the government and said, you have to stop this. This is clearly illegal. That case, they won that case in court, but they have not announced new rules that might come down to rein the process in. So if anybody is getting hit with an accumulator now, they're encouraged to tell their state insurance commissioner what's happening. But also, making rules is a very amorphous process. It can take time. It's not, they can change the rules later. If Congress passes the Help Copays Act and changes the law, done, all set in stone, then from that point on, anybody who gets assistance paying their copayment will have it counted to their out-of-pocket maximum, and you will hit your out-of-pocket maximum earlier and when you should be hitting it because the money has been paid in to reach it. I hope that makes sense. We're always happy to clarify this. There's a bunch of great resources from a coalition called All Copays Count that you can probably look up online as well for more background.
All right. Do we have time for one more, Dane? I know you have another meeting coming.
We do have time for one more.
All right. So are there any expected changes to Medicare prescription payment plan options?
Always anticipated changes, not always sure we know what they're going to be. So they can come out of left field, but this is a transparent process. So when the administration proposes changing something, they often go through rulemaking. There's a comment period. There's an ability to weigh in. And then, of course, Congress or Capitol Hill can always weigh in and say what they think, too. So some of this stuff is very complicated or technical, and they're not expecting you to be an expert on your care. But when these changes occur, if you notice it with your pocketbook, or if you notice it with the frequency or ability to see your care team or direct your care, that's what you should flag for your congressional offices. They will always be tinkering with this stuff. Sometimes they might make it better. And then you might say, great, I'm paying less now. But if you ever get hit with something that changes your out-of-pocket for the worse, or makes it harder to see your doctor or your care team or get physician-directed care, then that's the absolute type of situation in that affordability discussion that you should explain to your senators and representatives. And you don't have to have all the details. You don't have to say it's because this executive order was signed or this Federal Register notice went out. You just need to say, this happened to me. And then they will all even be able to research some of the information and figure out what caused it. And whether it was private insurance or a federal plan, may be able to intervene on your behalf. So there's both the immediate potential for help and then also the policy solution that could be developed moving forward. But those changes happen all the time. We try to keep track of them, but they are numerous. And the key thing that matters is, did somebody feel this in a way that changed their out-of-pocket costs or limited their access? And you would know that better than we would.
All right. Well, that is it for questions. I'm going to go ahead and wrap us up. Thank you so much, Dane and Kira, for joining us today and sharing your expertise. It's very much appreciated. We encourage you all to complete the brief survey that you'll receive after the webinar. It helps us ensure that we continue to provide helpful information and content. If you are not doing so already, please follow us on social media at Accessia Health to learn about other presentations and upcoming webinar opportunities. Again, thank you. We look forward to your feedback and have a good afternoon, everyone.